Vestibular webinar series, Managing Persistent Dizziness. My name is Helene and I'm the Workforce Development Officer here at Western Victoria PHN, and alongside me is Jade, who is also on the Workforce Development team. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. I'm dialing in from Wadawurrung country. We recognise their diversity, resilience and ongoing place that First Peoples hold in our communities. Just a little bit of housekeeping. You can view the majority of our webinar recordings freely on our PHN YouTube channel. The link is up on the screen at the moment, and also our upcoming events are on the screen. You can register for these via our website, and we'll also put that in the chat. We would like to highlight a few key face-to-face networking events happening across our region this March. Just take the advantage of an opportunity to network with peers and enjoy a complimentary meal at either a GP dinner or practice manager, practice nurse breakfast in whatever region you're in. Registrations are now open and you'll find them on our website. Please make note of the health pathways relating to this topic, and that's on the screen at the moment. If you have entered the webinar not displaying your accurate first and last names, could you type them in the chat box? Only the admin will see those. This is just to ensure that we will be able to get your certificate of attendance to you. For this evening webinar, all participants will remain on mute. If you have any questions, type them in the question and answer box and I can ask them on your behalf. There is a link to the chat box to complete the survey after the webinar, and we will show you this again at the end of the presentation. Our presenters for this evening are Dr. Tang, Neurologist, and Dr. Brendan Cutts, Vestibular Clinical Lead Physiotherapist, who will introduce themselves further during the presentations. Thank you, Lewis. Well, I'll hand over to you.
Great, thank you very much. Yeah, hello all. I'm Tang, one of the neurologists. I've got a couple of appointments around Victoria at the RVEEH Hospital and also at Geelong Hospital, University Hospital Geelong. Look, I've recently just done a fellowship with Professor David Shmulevich at the RVEEH in the Dizzy clinics. So yeah, thank you for inviting me to have my first talk as a consultant about persistent dizziness. And yeah, appreciate any feedback at the end.
I'll just jump in and introduce myself as well. I'm Brendan Cutts. I'm a physio working both at Neurophysio Geelong and at Barwon Health, both in Geelong. And my special interest obviously is dizziness, and so I see a lot of people with persistent dizziness.
Okay. Alrighty, so just a brief outline of what we will go through today. Next slide. So when dealing with persistent dizziness or any patient that comes with dizziness, I like to sort of set some definitions, because often you'll have patients come in and use these keywords like dizziness, vertigo, and unsteadiness or lack of balance. However, they may not use it the similar way that we as neurologists or physiotherapists may use it, and that can lead to some confusion for the patient and to the practitioner. So dizziness is a perception. It's a sensation, right? It's like other sensory networks in the brain. It involves a lot of areas of the brain, basically the whole brain, and it's highly subjective. So it's not really sensitive or specific to vestibular pathology. But nonetheless, it's important to keep that in mind, because that can lead us down certain diagnostic algorithms in the absence of other symptoms. Now, vertigo technically is a false sense of perceived motion, whether it's they they see things spinning, and practically that's why I like to ask patient early on whether they see things spinning or do they just get a sense of dizziness in their head. And it helps you a little bit because practically if they see things moving, that should be associated with nystagmus, a pretty hard clinical examination finding. And that can, again, help us with our diagnostic reasoning. The basic physiology for nystagmus is a tonic imbalance between the vestibular organ inputs into the brain, or it can be an impairment in the central integration of your vestibular signal. So it's not really a differentiating between peripheral or central, but rather it helps you understand there's probably a structural issue happening. Lastly, balance can be a perception, but we do have a bit more objective measures for it, such as the bedside exam or a gait analysis lab. Next slide. So just going to address the big elephant in the room. When a patient comes in with persistent dizziness, oftentimes, at least for me and in the early days of my training, I would think, oh, is it something functional, or in this case, persistent postural perceptual dizziness, PPPD. And that's really not unbased, because there have been a few big studies looking at what are the reasons and the causes for chronic autologic disorders, and the most common is PPPD, up to 40% in specialist dizziness centers. And this phenomenon has been known since the 1800s, and it has gone by a few other names in the past. It does have a more female predominance, about 2 to 1, and the average age of the patient suffering from this condition is, in the middle ages, between 53 to 59 years old. Another elephant in the room when confronted with a patient with persistent dizziness is, are they faking it? Maybe I'm just speaking for myself. In my early days, there is a thought that comes into our head: is this person trying to, pull wool over my eyes or trying to get something out of me? I got this sort of cartoon or diagram from the psychology database. And I'm not a psychologist or a psychiatrist, but basically, they separated out into somatic symptom and related disorders, which in neurology we call it functional neurological disorders, and factitious disorders, and even what's malingering. It boils down to, their intent and their gain, which are both very hard to assess, especially if you're not trained in mental health and you only see them on your first visit. But the saving grace is that people who linger or have factitious disorders are actually very rare. And again, people have looked into these sort of things, and I guess evolution has made us very good at picking up whether someone is trying to abuse or exploit our trust. So I think for the most part, people are not trying to fake their condition or trying to get something out of you. And if they are, instinctively, it will be quite obvious. So I guess is to try and be conscious of that and not have too much bias, or it may lead you down the wrong diagnostic path. Next slide. I think this slide is just to show that the vestibular organ is very sensitive, and it has a high range of limits where it can pick up movements compared to vision and proprioception. If Brendan wants to add further onto this slide.
Yeah, you've summarised it well there. The main thing is that when we're standing still, our proprioceptive system does most of what we need to in keeping us steady. And you can imagine that vision will be helpful in using depth perception to identify where we are in space, but usually in quiet stance, when you're not moving, proprioception can do everything that you need it to. And as we move through space, vision really helps in determining where we are and how we compare to our environment. But particularly where vision is not effective, then the vestibular system really takes over. And that'll be anywhere where we have reduced vision, like in the dark, or where our visual environment is moving, like if you're in a moving car and you've got traffic around you, or you're on a boat and the horizon's moving as well. But also any time that you're moving really quickly so that vision can't stay stable. And so things like running or quickly turning the head, like doing a head check, are often well beyond the maximum velocity that the vision can manage. So we're constantly using these three different systems in different environments, and your central processing, works to try and determine which is the most appropriate at which time as well.
Thank you. All right, so this is just to bring the point that when we talk about the vestibular system, it's more than just the vestibular ocular reflex that I think a lot of us are familiar with, with the head input test and the positional testing for BPPV. We got our semicircular canals and our otolith organs, the utricle and the saccule, that basically perceive angular and linear velocity changes and also gravity, and it's helps the eyes move in equal and opposite direction to head movement to maintain a stable gaze. However, it also extends down to the brainstem and also the spinal cord to make micro adjustments instinctively to keep us in an upright structure. And those are the vestibular cervical reflex and the vestibular spinal reflexes, which would be important in some of the symptoms we talk about later. Okay. In terms of neuroanatomy, right? With neurologists, we're always talking about where is the lesion? Can we localize the lesion? Is there a primary vestibular cortex, like the primary motor cortex? No, it's a complex interplay of a lot of different cortical and subcortical regions in the brain. And I'd just like to point out the occipital cortex, you can see, is not really highlighted in this network. And leading back to what Brendan was talking about, it sort of makes sense, right? We can walk in the dark. We don't necessarily need our eyes to be able to walk or run. Our vestibular and proprioceptive networks are quite capable of keeping us, steady, whether it's gait or stance. Now, in PPPD, there are some emerging evidence through functional imaging that shows there are changes to the network connections between different areas involved in vestibular information processing. In particular, there's increased connectivity between the prefrontal cortex and the primary visual and motor regions. Again, keeping that in mind, because we'll talk about people becoming more reliant on their vision as part of their symptom complex. But I sort of bring this up just to show, PPPD is a real condition. There are changes. However, it's just not something we can pick up routinely on clinical exam or clinically available investigations. Okay. Personally, I see PPPD as a subcategory of FND, functional neurological disorders. Some people will have some controversies with that, but this is just how I understand this whole picture. Now, I'm not a psychiatrist or a psychologist, so this is my quite superficial understanding of the theory behind this, so bear with me. It sort of centers around this agency network and the disruptions in that. The agency network it's a network in our brain that gives us a sense of self and being in control of our body and sensations, and it receives inputs from the feed forward and feedback system. A lot of people are familiar with the feedback system, where we get sensory information from our joints, our sensation, our eyes, but personally, I didn't really know about the feed-forward system, which is a system that sort of plans and executes our actions, and it sets some expectations of what the feedback information should be. And that's developed through, years of experience and life challenges and things like that. It's thought to be centered around the premotor area and the limbic system, which makes sense. That's our executive planning areas and our memories and emotional centers. In people with FND or PPPD, there is a disruption in the feedback feed-forward systems. Basically, there's an overemphasis of the feed-forward system, and there's a filtering of the feedback signals, leading people to jump to conclusions or cherry-picking the information that they get back from the other parts of their body. Over time, this can lead to the novel neuronal pathways that we see on the functional MRI, and that leads to the symptoms in PPPD and FND. Again, it's just try to emphasize that PPPD symptoms are real. It's just that we don't have a gold standard biomarker for it yet. A note is that reflexes and automatic movement uses a different mechanism. It bypasses the agency network, and hence that's why distraction techniques work. For example, the Hoover sign. Now, thinking about the causes of FND, it's not like some of the more organic conditions where there's one thing goes wrong and explains all of the problem. You sort of require three things, right? You need a patient who are vulnerable to FND, and generally that is people with mental health conditions, especially those who are suboptimally or not treated, especially in anxiety and depression. Certain personality types are more susceptible to these things as well, increased body vigilance and such. There usually is a precipitating factor. In our case, usually it's a very bad migraine, vestibular migraine flare, BPPV, or vestibular neuritis. The third part is more on us as health professionals, where we're on the fence about the diagnosis. We're sort of shy about talking about FND and PPPD, or the patients go and see alternative medicines, giving them some strange ideas of what's happening or what's the cause of their symptoms. And over time, a few cycles of this negative vicious cycle can lead to all the problems that we see in clinics few months or years down the track. Next slide. So how can we explain some of the symptoms we see in PPPD? So taking an example of a patient who suffered an acute vestibular event, whether it's bad migraine or let's say vestibular neuritis, right? They have weakening of one side or both sides of their vestibular organs, so their body will try and prevent falls. Some of the strategies it employs is, it increases the constraint on movements to reduce the amount that your body can sway. This results in a stiffened posture, which takes more energy. The second strategy is whether you don't trust or you have impaired vestibular or proprioceptive inputs, so your body would require or desire other inputs to help you remain balanced. And in a lot of cases, it's the visual input, and that makes people more susceptible to optical illusions, and they often cannot tolerate complex visual stimuli. So it's not uncommon to see patients get problems when they go into the shopping center or even watching a TV show where it has a lot of things happening with a lot of action. I think I have a little picture coming up. So, for us who don't have, vestibular disorders, at least for me, this picture is moving, right? It's quite complex. It makes my eyes jump from here to there everywhere. So you can imagine patients with PPPD have a lot worse symptoms, or like it can be quite nauseating or debilitating. Okay, thank you. The third strategy is they become more vigilant to movement, to changes in their body position. And that is a function of the reduced tolerance for errors between the feed-forward and feedback systems. And then lastly, generally the body sets an energy limit on how much it can use to maintain balance. After certain vestibular events, that energy constraint can be removed to keep us safe. That, in conjunction with the excess energy use, can lead to a lot of patients complaining of fatigue. Now, we talked about a case where a patient has an acute vestibular event, and these symptoms can develop quite quickly or temporally since their first event. However, it can also come up quite insidious and slowly for patients who have chronic medical illnesses. So you may not always have that initial precipitating event. So it's important to go through their past history and explore whether they have something else that is more chronic and untreated. Lastly, the last point is talking about would PPPD cause cognitive impairment? Yes, but not in the typical sense. It's not like a dementia or anything, or like migraine where they have disruption, cortical depolarization, and release of all these inflammatory peptides. It's more to do with the fact that these patients can become so preoccupied with their dizziness sensation and their posture control that it eats into their energy for cognitive tasks. And it can be quite severe to the point where it impairs their cognitive ability more so than people with migraine. So it is something important to keep mind of, and not to discount patient when they say they can't think. There is a reason for that. Okay, next slide.
I often tell people that they're so busy concentrating on figuring out how to balance and move all the time that they yes, using more energy for day-to-day tasks, and that's leading to their fatigue as well as having less marbles spare for their cognitive tasks.
That's right. So this is more of a table for a lot of the other symptoms you get in PPPD, and the physiological and psychological data, and the neurogen data evidence to relate to these symptoms. This is just a cartoon of summary of what we talked about, the precipitating events leading to these strategies that keeps you safe from falling, but over time, it can lead to maladaptive neuronal pathways and symptoms of PPPD if not treated. Okay. So investigation, do we need to investigate patients with PPPD? Now, strictly speaking, people who have purely FND or PPPD don't have structural pathology that we can pick up with clinically available tests. So unless your history and examination raises red flag of other concurrent, either neurological or vestibular pathologies, I'll practice, whether myself or at the Balance Disorder Clinic at the INEA, is to not investigate, because that can be part of the negative vicious cycle that enables some of the maladaptive symptoms that patients experiences. And some of the important clinical exams to do is, of course, a neuro exam, particularly the cerebellar exam, but also the Dix-Hallpike and the head and post test. And if you're more savvy, you can do some of the other positional testing as well. John Waterston and friends did a recent paper, I think a couple of years ago, where they tested a lot of patients with PPPD using formal vestibular function tests, and unsurprisingly, the majority of them have normal testing. Now, there are some abnormal findings that they did find, and one I would like to point out is the unilateral hypofunction, the 18% one. I think that's more the patients who had vestibular neuritis, or they had Meniere's or something like that, as a precipitating event, and wasn't treated and became PPPD, and then they found this unilateral hypofunction. The non-specific positional nystagmus probably talking about the patients in vestibular migraine, where you get central positional nystagmus. The isolated otolith abnormality, look, that's very non-specific. We know the CVAMP and OVAMPs are not that reliable, especially when it's the only abnormality found. And yeah, very little patients had BPPV. So it's worthwhile doing all those exams that we talked about, okay? So going into the PPPD criteria, look, hopefully through the slides that we talked about, it makes the diagnostic criteria more understandable. And I think on the official Barani criteria at the end, it makes a point that PPPD is not a diagnostic, a diagnosis of exclusion. It is very common to be coexisting with some of the other conditions. So, it's not that they don't have anything else, they can only have PPPD. They can have both. Okay. So what are the differential and coexisting conditions? So these are some of the ones, BPPV, vestibular migraine, vestibular neuritis, and Meniere's disease that we will be dealing with most commonly, and more rarely is the structural conditions, but they should be pretty obvious, especially on examination. And of course, these non-vestibular conditions always worthwhile checking. So by far the most common coexisting condition we see is vestibular migraine. It does have some overlapping mechanism as FND, PPPD, but it's quite different in terms of the nitty-gritty and the areas where it's affected. Clinically, it should have a more distinct waxing and waning pattern, with the auras and the premonitory symptoms that we get. And that relates to the pathophysiology, where there's cortical spreading depolarization, leading to the release of neuroinflammatory peptides, and you get the symptoms like headache and non-headache symptoms. We mentioned about the central positional nystagmus. There are more established evidence for treatment, although it's not saying much because the treatment evidence for migraine is still very low. For the most part, we do treat vestibular migraine the same as your general migraine. And I think a lot of you guys would be familiar with the Australian therapeutic guidelines about what medications are available for migraine treatments. So when you have a patient that has failed multiple migraine prophylaxis, especially the injectables like Botox or Ajovy, then it should raise some red flags about whether you are dealing with vestibular migraines or something else. Okay.
I'll just add that there's obviously emerging evidence for the pharmacological management of migraine, but there's now for vestibular migraine reasonable evidence for an equivalence in vestibular rehab and other non-pharmacological management strategies for patients. And so there's certainly a subgroup of patients that definitely need involvement of medications and from either GP or neurologist, but then there's also patients who are entirely able to get on top of both their migraines and their symptoms through non-pharmacological management.
Yeah, so the vestibular migraine criteria is helpful, though there are some caveats, and personally, I don't follow it to the T because, you know, they talked about headaches, and I think in our experience, headache doesn't need to be a, not everyone needs to have headaches. I see it being a spectrum. Some of the migraine patients have, headache and non-headache symptoms, and there are patients all along that spectrum. So I'm not quite sure about someone who doesn't have headache doesn't mean they can't have definite migraines. Okay, so the next is Meniere's disease. On the outset, I would just like to say it's very rare. It's about 10 times rarer than vestibular migraine. We're talking about 0.1% incident. So although there are some overlapping symptoms, and sometimes it can be a little bit tricky to discern between the two conditions, if you are confronted in that situation, then one, refer the patient to a specialist or the ENT or neurologist, or two, if you're a betting man or a woman, put your money on vestibular migraine. It is a lot more treatable anyhow. Now, and that sort of the clinical pattern, without going into too much detail, again, it does have quite a distinct waxing and waning pattern, and that's because of the structure. The semicircular canals and otolith organs is surrounded by fluid compartments, and for whatever reason, people with Meniere's disease tend to have more fluid in the scala media section, and when it reaches a critical mass, it causes a rupture of the vestibular membrane and a fluid shift, and that results in the disruption to the normal balance of ions in the fluid surrounding all your vestibular organ structures, and your hair cells becomes dysfunctional, leading to your dizziness, nausea, nystagmus, and sometimes even hearing problems down the track as well. So what are the hearing patterns, hearing loss pattern that we see? It first affects the low frequency, then the high frequency, and then at the end, the mid frequency. So you'll see us upslope, a triangle, and then a flat line in terms of the hearing loss. And that should fluctuate in the early stages in the low frequency between attacks. And that is part of the diagnostic criteria. So look, basically, it's very difficult to make the Meniere's disease diagnosis, and one shouldn't jump to that diagnosis without going through the rigorous screenings, mainly because of patients can get hung up on that diagnosis, and sometimes that can lead to diagnostic uncertainty, makes the PPPD worse, or it can lead to harm, like people get gentamicin injections or vestibular nerve resections and losing hearing, and get their balance all disrupted. So it's not great. And that's just the diagnostic criteria, more in detail.
And just again to reinforce that Lewis said how rare it is. I think one of the common things we see is that people come in reporting 2 or 3 day episodes of dizziness, and they're often really clear cut that that's due to vestibular migraine. It's quite rare for people to have really severe dizziness and potentially oral signs as well that last for just a couple of hours and are kind of safely inside the Meniere's disease criteria. And if we jump down to point B, you can see that the criteria call for having a 30 decibel change in the low frequencies on a hearing test. And that's really challenging to actually get done because when you're really, really dizzy and vomiting, the last thing you want to do is come in and have a hearing test. So in practice, it's quite challenging to get the hearing test done. But we we'll often dwell on point C with the fluctuating oral symptoms in conjunction with the brief kind of multi-hour episodes of severe vertigo to come up with a diagnosis. This table just compares the two diseases, Meniere's and migraine, and Lewis has already gone through these in quite a bit of depth. One thing I will say is if you just scan it quickly, you can see that migrainous symptoms during an attack can be present in both conditions. Cochlear symptoms during an attack can be present in both conditions. And there are some pointers that are difference or points of difference between hearing changes, vestibular symptoms. But again, the attacks really can vary for vestibular migraine from minutes to days. And of course, that includes the multi-hour attacks that are common in Meniere's disease. So in many patients, it's quite simple to delineate. And then there's also a group that it's very challenging to come up with a really good solid theory as to which one they're suffering from. And of course, there's a very large proportion of migraineurs in the Meniere's disease cohort as well, well beyond the normal level. So there would be definitely patients with a crossover of the two types. I've just amended your slide here, Lewis, because I wanted to highlight that lifestyle changes are really important with this group. And Lewis will probably touch on the fact that the medications have a lot of study behind them, but not a lot of efficacy. And so a lot of patients we find can get on top of their attacks just through salt-restricted diet and avoiding caffeine and alcohol, which as diuretics will have more of a fluctuating effect on their blood volume and plasma volume. So we really try and reinforce the salt restriction and then refer to our colleagues for the medications.
Yeah, so yeah, you're right. The basic RCT we have is surrounding the beta hissing, and everything else is retrospective data. And that's not to discredit them, but it's just to say, we will try them. The response per patient may fluctuate quite widely as well. And the beta hissing is more about tolerability and safety. Although in saying that, I do get patients quite commonly, or not uncommonly, saying, they swear by it and it's a very effective prophylaxis. So look, there are a lot more studies to be done in this area, I think.
It also seems like it's pretty unusual for ENTs to go as far as gentamicin and sac surgery, but there seems like there's an increase in intratympanic steroid injections these days. So BPPV is a very mechanical issue here. You've got otoconia, which are these little crystals that lots of patients know about and talk about. Crystals sitting on the macula, which is the main sensory processing part of the utricle and the saccule, the two otoliths in the inner ear. And they're there to really weight the hair cells and make sure that you get a response when you tip your head forward or you accelerate forwards or up and down. Now, if those otoconia come loose and they fall down into one of the canals, which commonly happens overnight when your ear's tipped back, then you'll get positional dizziness. As the otoconia move through the fluid in the inner ear, they'll push the fluid towards the closed end or pull the fluid away from the closed end, and that, using the vestibular ocular reflex, will generate nystagmus and a feeling of spinning. So these patients usually have a very obvious onset of their dizziness, and it's typically quite severe. But I will say that many older people really may not sense their dizziness very much. They could have had it there for a very long time as well. And so it might be more of a 3PD mimic by provoking just a general sense of imbalance, sometimes some dizziness, with position change. And so similarly to the diagnostic criteria of 3PD being more about being dizzy and unsteady when you're up on your feet, that can often happen for people with chronic BPPV. And repeating that the Dix-Hallpike test is the gold standard test for BPPV. We won't go into any more detail on BPPV today. Vestibular neuritis usually is also a really obvious onset of dizziness for people, very memorable onset of dizziness, accompanied by nausea and imbalance. And given that the main differential for vestibular neuritis is posterior circulation stroke, in the subacute phase, people will notice oscillopsia, so they'll have issues with their gaze stability. When they're walking around, they might feel like their vision's bouncing, like the old JV cameras, the old camcorders that people used to have. And they might also report dizziness, unsteadiness when upright, similar to 3PD. The rapid head impulse test is what we use to check for failure of the vestibular ocular reflex, which will be, which is what happens in vestibular neuritis. And Lewis, did you want to touch on vestibular suppressants there?
Yeah, yes, sure. So after acute vestibular event or vestibular neuritis, there will be a lot of central adaptation. Without going into detail, your cerebellum will sort of modulate the signal it gets between the two vestibular nuclei and sort of balances it out. And if you use vestibular suppressants, Stemetil, Maxilon, or the like, it can impair that process, leading to chronic imbalance in the signals, and that leads to chronic dizziness and even PPPD. So I usually reserve the use of vestibular suppressants for very severe vertigo. So patients who come into ED and vomiting and they can't eat and they can't stand, I will give it to them in that setting. However, I limit the use to 3 days because of the risk to the central adaptation.
Vestibular paroxysmia. These are this is a fairly rare condition, but probably also under-recognised. These are very brief, usually in the realm of multiple seconds up to a minute, but there's probably emerging or discussion around the criteria being expanded beyond that time frame. But there are frequent episodes of dizziness, and it can very much be a spinning dizziness. Sometimes there will be accompanying tinnitus or facial spasm because the facial nerve runs right next to the vestibular cochlear nerve. But often these patients will also have this lingering sense of feeling unsteady as well, which is where this is a reasonable 3PD mimic. The MRI brain will usually or can uncover a vascular loop over the 8th nerve, and the microvascular compression of the nerve is what causes these frequent symptoms. Now, they might seem like they really should be position-based, but often they're spontaneous in nature. And as we pointed out, the anterior and inferior cerebellar artery is usually to blame, but it can be one of a number of arteries and veins. And at the end of the day, it doesn't really matter too much. Lewis, did you want to talk about medical management there?
Yeah, so I see it the similar, well, in principle, it's similar to the trigeminal neuralgia, right? It's like the vascular compression or irritation of the 8th nerve instead of the 5th. And the treatment, I think, evidence stems from that, and they use the same thing as carbamazepine. Some neurosurgeons will say there is no max, so I've seen patients up to like 1,400 milligrams a day, and sometimes it does require that high of a dose, but usually you can start something between like 200 milligrams daily and slowly titrate your way up. And it is generally quite effective, although there are certain patients which are refractory and severe, and unfortunately will need to go under the knife and get a microvascular decompression surgery.
There are diagnostic criteria which are pretty handy, and one of the main ones is their response to carbamazepine. And in the literature, at least 90% of patients with vestibular paroxysmia do respond to it as well. So kind of supporting the idea that it is related to this microvascular compression. But unfortunately, the vascular loop's not always there on MRI, and equally, the presence of the vascular loop doesn't always mean that the person has vestibular paroxysmia. So we do want to rely on the diagnostic criteria being fulfilled. Lewis, do you want to talk about milder debulkment? This is
so they talked about this in the most recent, I think, Barani pre-conference meeting. And look, I sort of see it as perhaps a extension of a normal adaptation, because I'm sure a lot of us have been on a boat or a plane and you get off and you feel that, waviness feeling. But in certain patients, they sort of extend beyond that and become chronic. I don't think we have a good explanation of the underlying pathophysiology, but some of it's probably within that PPPD spectrum as well. But there are the society has pointed out some differences between PPPD, in that PPPD is generally worse with standing, but milder debulkment is not worse with standing, and it can be better when they're in passive motion, like when they're in a car or a plane or a boat. That is, sorry, go ahead.
I was just going to say, they often really describe their rocking and bobbing sensation, and sometimes can really give you a frequency that they're moving internally at. Often, usually not obvious externally, but sometimes if you can get them to close their eyes, they can describe the pattern of their movement and how they're moving, which has eventuated in some treatments that are offered in the US for MDDS, but there's really not much in Australia for these people. It's a really complicated algorithm of treatment yet to develop. Yeah. Some other differentials just to touch on. Postural hypotension obviously will feel very similar to the dizziness you get when you stand up in 3PD. So that's a really common reason, both to precipitate 3PD, but also as a differential diagnosis. Fistulas in the either the semicircular canals or other places in the inner ear will affect the fluid dynamics of the inner ear at all times, but in particular when you move in the plane of the particular canal that's affected. And usually that's the anterior canal or the superior canal, different names for the same thing, that rises through the temporal bone to just underneath the brain. And again, this is something that's really commonly diagnosed on MRI. There have been cadaver studies of with temporal bone mapping looking at something like 1 to 2% of patients having a semicircular canal dehiscence, but in practice this is actually quite rare to see as an issue, and our audiologist colleagues are really good at with their diagnostics in determining whether this is truly the issue for the patient, but as well there's some kind of more obvious things that they report, like being able to hear their eye movements, being able to hear their pulse, being able to hear their teeth move or their guts churn, as well as pressure-based dizziness, so any coughing or sneezing, and that sometimes also generates nystagmus in these people. POTS, in a similar way to postural hypotension, can cause dizziness when upright, and autonomic dysfunction of any cause, whether it's neurogenic or cardiovascular or anything else, also giving issues with hypotension. And then medication side effects is another common one that we see at the Barwon Clinic as well, where people will really only notice how they're feeling when they're up and about and moving. Did you want to add anything there?
No, yeah, just the chronic opioid use, and yeah, that is a big problem for multiple reasons. But yeah, especially in the elderly, it can cause a lot of chronic dizziness. So just watch out for that and try and use some less, I guess, dirty medications for their pain. All right, so going into the management of 3PD, it's there's the non-pharmacological and the pharmacological. So think we'll talk about the pharmacological treatments first. Look, to date, there's no randomized controlled trial evidence, but there are some promising retrospective data from a while back, and people are continuing looking at it for SNRIs and SSRIs, in particular sertraline, escitalopram, citalopram, and venlafaxine. Now, I've got a table here about some of the suggested dosing regimens for some of the medications. It's just to point out that you don't have to go to the high doses in the absence of psychiatric comorbidities. And longer duration, more than 3 months is probably a good trial period. And so that would be the same as, migraine treatment. You give patients 3 months. If they're not responding to it, you would change. And the last point, this is more anecdotal in my experience. I find that patients with FND or PPPD often are more prone to side effects and sometimes paradoxical side effects of especially antidepressants. Not quite sure what it's from, but the point is to spend a bit more time discussing the treatment options, especially if you're going to use our antidepressant, and to explain that it's not because we think they are crazy or depressed, but it's the medication that has the evidence for some of the symptoms. And I usually use that as a entry point into discussing their psychological issues down the track. Okay. So cognitive behavioral therapy is actually quite useful, and you have to be careful who you refer to. Just like neurologists, they will have subspecialists in psychology and psychiatry who specialize in FND, PPPD, and they will be more experienced in how they discuss it and talk about the treatments. And studies have shown that it reduces the medication dose required to treat the PPPD symptoms. And the role of, I guess, GPs and neurologists, or any physician really, is to make that early diagnosis and educate the patient about PPPD, to reinforce that it is a real condition, just to avoid some diagnostic uncertainty down the track, and patients go see some alternative medicine. For example, I've had a guy come in who saw a chiropractor and explained to him that the vestibular nerve was impaired because of his C5-6 impingement. So it's things like that that can really be difficult to untangle and bring him out of that, misinformation. So if we can nip the issue at the bud, it'll be very helpful down the track for you and the patients. And this also, the table on the right, just to show how effective it is when you have CBT, early diagnosis, medication, and vestibular rehab therapy that Brendan was going to talk about. You see some dramatic improvements to the symptoms based on the symptom severity scale done by John Waterston a couple of years ago, only after 6 visits of CBT. And look, PPPD is very treatable.
Yeah, and again, actually just going back to those, there we go, those 3 pillars there of treatment. Vestibular rehabilitation, as in physio, seems to be the most acceptable to patients doing physio exercises. And then a proportion will be happy to go and see psychology. And then probably a smaller proportion, again, will be happy to go on medication. But I think the studies show that they're probably all equally beneficial to people. And so whichever pathway patients are happy to go down, we just kind of encourage them tackling their symptoms in one way or another, whichever way is most appropriate for them. So as far as vestibular physio goes, some of this I'll try not to repeat, but we expect to see nothing out of the ordinary on our oculomotor findings. Obviously, Lewis showed that sometimes vestibular function tests can pull out something out of the ordinary, but in bedside examination, typically everything's quite normal, except for the fact that it might irritate their dizziness as we do it. We usually see dizziness with head movement and sometimes also visual motion sensitivity. And that can come across as either sensitivity to the pattern like Lewis showed, or maybe something as simple as a checkerboard. Or it could be that in the supermarket, with all the light and sound and the cognitive task of finding things, it really triggers their dizziness. And then there's probably a group of people as well who are really susceptible to being in a car or driving in a car and having say the shadows of the trees flashing across their vision in front of them. We often see people moving in much more guarded patterns, despite the fact that structurally everything looks like it's normal. They can have really poor confidence with their balance and be very reluctant to get anywhere near the edge of, or the kind of the physical limit of their balance. And there'll be a gap between how much they feel like they're swaying and what they're actually swaying. And so they're, you know, if we set them up on the foam and they're just moving a very little bit, I might judge that as maybe 1 or 2 out of 10, if 10's the most they could be swaying, and they might say it's a 5 or a 6. And that's a really common finding and something that reinforces to me how they're feeling. And then probably a cohort of patients who are slightly more down the FND spectrum of things, who have a really variable performance in their balance testing. And in these people, we see that their balance tests improve as they get more challenging. And so they might, with feet apart and eyes open, they might be swaying back and forth, but it might be very nicely controlled. But by the time they get to feet together, eyes closed, or even standing on one leg, then the sway's all gone and they're putting in their best effort. And so it looks like they're doing much better. This is very similar to Lewis's slide on FND, but just reinforcing that for most people, they will have a dizzy trigger. That might be a vestibular event. And then they have what everyone has, the high-risk postural control strategies. So that, you know, how you might walk if you're on ice, being more focused on your vision as a source of truth for all your sensory systems for your balance, and being really vigilant of your environment. Now, that's the normal, and for most people then go on to recovery and go back to normal once structurally things go back to normal. But in these patients, we see the fall into the maladaptation cycle there, 3PE. So normally, as I was saying earlier, we really try to weight our different sensory sources to come up with a really accurate representation of the world around us and how we fit into that world and how we're moving within it. And so when you have dysfunction, whether you've rolled your ankle and your proprioception is not very effective, or you have an injury to an eye and you can't use your vision so well, for some people that's just getting new glasses. But also if you have a vestibular event and you have hyperfunction, for example, then that's going to change how you keep weighting your balance systems for your balance and movement. I've just got a picture of Batman there because he's good at operating in the dark. So he's someone that's obviously very used to not using vision as an input. People that are jogging are also very used to not using their vision because the vestibular system helps keep them steady as they're bouncing up and down. And then someone on a boat without a static horizon to anchor their vision to needs to also have a very compliant vestibular system. The goals of vestibular rehab for people with 3PD are to reduce that visual anchoring that they are using. And so using their other balance systems, kind of trying to refine their other balance systems. We want to improve their tolerance to head movement as well, given most of them are dizzy with head movement. We also want to be comfortable getting close to the edge of their physical ability in their balance, because that's one of the main risks for falling is just having a fear of falls. And so for these people, keeping them safe is usually around making sure they're comfortable managing their balance when they're at their limit, using appropriate, step strategies, rather than trying to grab for things and looking around for what they can lean on. And then for anyone that's had their dizziness for a while, they'll often have movement limitations. If they've had BPPV in the past, they might be really reluctant to lay all the way down. They might be sleeping on a bunch of pillows. Some people confine themselves to a chair rather than a bed anymore. And for others, it's, they've stopped bowling because they have to put their head down. They can't do their normal shower tasks, things like that. So typical treatment along those lines is really trying to reinforce getting rid of the visual system. So a lot of balance tasks, whether that's static or dynamic tasks with eyes closed. Balance tasks, again, with the head moving beyond the speed that the vision is the main source of input. We want to consistently provoke mild symptoms, but never provoke symptoms worse than that. Because we want patients to keep having positive experiences with their symptoms. And I don't mean that positive as in wonderful, but positive as in no real negative connotations to how they're feeling. So not provoking panic-like symptoms, being in control the whole time and being able to kind of turn off their symptoms through rest or mindfulness activities when they can. And then they'll have a graded return to exercise and other daily tasks as well. Just wanted to mention the service that Bowen Health offers as well. So obviously there are private options, and with private options, you can, for physio, you can usually get in very quickly. Bowen Health also offer a vestibular service that has audiology and physio, and often able to escalate care to ENT if required as well. This is something we're trying to organise Lewis to come and join us with as well. We'll provide a report back to the referrer and or the GP, well, always the GP and or the referrer, I should say, regarding assessment, and then offer them ongoing input if they need it. And that referral is on the Bowen Health Audiology internet site. So if you go on the Bowen Health internet site and type in audiology, and then scroll down to the bottom, you'll see the link to the referral forms. Key references here, if you want to do more reading about 3PD, at the bottom there's the paper by Popcorov, Starb and Stone, who are three really experienced neurologists with both functional disorders and functional dizziness, 3PD, and is a very readable paper in a review format. So gives a lot of great information, examples, tables, lots of pictures, really as engaging as a paper can be. And then John Stone also has this website, neurosymptoms.org, where there are fact sheets on all sorts of functional neurological symptoms, including 3PD. And that's a really good resource, both for clinicians and for patients to turn to get more information from a neurologist. So some final takeaways. Lewis, go ahead.
Yeah, thanks. So, yeah, hopefully we've hammered in the point that PPTD is a real condition. It's not a diagnosis of exclusion, and it can occur with a lot of other vestibular or medical diagnoses, which can commonly coexist with other vestibular and or medical diagnoses. So there is a bit of complexity in this. We do want to make that diagnosis of PPPD early and try and be stigma-free and educate the patients. Treating this complex condition does require a multidisciplinary approach, using pharmacological and non-pharmacological strategies. For acute vestibular syndromes, we do want to avoid the chronic use of vestibular suppressions. And lastly, it is a marathon. Treating people with PPPD takes a while. Usually we're talking in the area of months or maybe even years, because some of these patients can come in where their symptoms have set in after months or years, and a lot of this neuronal pathway reorganization and confidence building, and sometimes patients can become physically deconditioned through, maladaptive behaviors. That takes a lot of training to get everything back on track. So please don't be discouraged, and, ask for help when needed. And we're always here and available at, Barwon Health or Epworth or Neurological Physiotherapy Geelong.
That's the marathon.
Yeah.
All right. Any questions? I'll leave you with our references, but that's the end of our talk.
Yeah. Thank you to both speakers for a very informative presentation tonight. I do have one question: how to examine a dizzy patient who doesn't have eyes? This is in regard to a previous MVA where glass shards went into the eyes and both eyes were surgically removed.
It's pretty difficult. I will say sometimes a glass eye has enough traction around it with extraocular muscles that you will still see movement, but that would be pretty unusual. I think I've had this challenge before with blind people, that it is very challenging. But yeah, eyes that are not actually attached to muscles makes it really, really hard. And beyond, for me, I would just try and go through particular maneuvers and movements to try and guide exactly what was bothering them from a dizziness point of view and imbalance point of view, to try and match that up with what I know of particular dizziness conditions. But that's pretty hard.
Yeah, I agree. Personally, I haven't had to deal with that situation myself, though. Going back to first principles, you got to get into the history and the other neuro exams, because that can narrow things down quite a lot as well. I guess in terms of BPPV, you would still be able to elicit, sensations of vertigo in certain positions, and you could try positional maneuvers if you do suspect BPPV. And admittedly, things like vestibular neuritis will be a bit tricky because all our equipment does rely on pupil tracking. So you wouldn't really be able to tell if there is reduced vestibular input from either side. So, but you will work through, like Brendan said, the other conditions like vestibular migraine and Meniere's. You can get a lot from history and exam.
I do have a question. Is there anyone in the Warrnambool area offering vestibular rehab that you know of?
Yeah, there are clinicians training up in this space in the Warrnambool region. To my knowledge, they're working in the health service, so I would start by referring to Southwest Healthcare, and Southwest Healthcare, being part of the Bowen Southwest region, are able to and do have links with Bowen Health, and so we provide, I guess, a supervisory service to their vestibular clinicians or the physios interested in vestibular rehab.
Thank you. We'll just finish up. We've run a little bit over time. Just one more question. In someone with a severe TBI with significant cerebellar damage, it is reasonable to expect a level of persistent dizziness that can never be completely resolved?
Probably. I think it's hard. Yeah, I don't want to be too optimistic about all cases of 3PD. We're certainly in all conditions there are patients that don't make a full recovery. So in a N of 1 type case examples, you never want to say that the person should always get back to being symptom free. So yes, I think there will always be conditions that relapse and remit or cause ongoing, that have ongoing central dizziness that are hard to get on top of. But in a patient with enough cognition that they're able to learn from their experiences, and I mean that in a neuroplastic sense rather than I don't know, I'm trying to time myself up, but with enough exposure to mild symptoms over a long enough period, you will keep getting change in their response to different positions and movements and things. And so you should, at the very least, keep expecting them to improve with enough exposure to the stimulus. Whether they make a complete recovery is a different question.
Yeah, I agree. Look, extrapolating from patients with, cerebellar ataxia or other, structural brain injuries, it is reasonable to expect that they will have some sort of symptoms, whether that be dizziness or incoordination. But, the brain is adaptable, and a lot of patients I do see, the cerebellar ones, that over time they sort of, for the lack of better words, they get used to it and it stops bothering them as much.
Okay, thank you very much. We will finish up on that note. For the participants, please take the time to fill out that evaluation survey. Put in any future topics that you may want on this subject or any other topic. We'll see if we can accommodate you. And thank you again for both speakers.
Thank you very much.
Thanks, everyone. Thanks for having us.